Hello friends, let us now learn the differences between hyperplasia and goiter. We have already learned about the thyroid nodules and what we see in a thyroid nodular disease in ultrasonography. So, if you see the hyperplasia and goiter, if you see the patient suffering from a nodular thyroid disease, in the nodular thyroid disease, around 80% of nodular thyroid disease consists of hyperplasias, whereas around 5%, sorry, 80% of thyroid nodular goiters, thyroid nodular disease constitutes about hyperplasia, and this 80% will account for 5% of normal population. So, if you see the etiology of thyroid nodular, that is hyperplasia or goiter, hyperplasia and goiter can occur in conditions of iodine deficiency, that is, in conditions where there can be endemic goiter, or it can also occur whenever there is disorders in hormonogenesis, that is, dysharmonogenesis, where hormones are not properly formed. Okay, now what actually happens is there is hyperplasia of thyroid gland, right? Whenever there is hyperplasia of thyroid gland, and if the size of the thyroid gland will increase diffusely, this will result in formation of a goiter. Okay, when the size of the thyroid gland or volume of the thyroid gland increases diffusely, then we call it as goiter. This goiter is most commonly in the age group of 35 to 50 years. It is more common in age group of 35 to 50 years, and it is also seen more commonly in women more than men. So, if you see histologically, in the cellular hyperplasia, in the beginning, there is just hyperplasia of thyroid acini. That is, there is the first it starts with hyperplasia, and followed by whenever there is hyperplasia, there will be slowly as it increases in the thyroid gland, you will see formation of a micronodule. Okay, this micronodule will also increase in size, and at the end it results in formation of a macronodule. Okay, followed by which you will see this appearance where there is, here you can see presence of hyperplastic nodules are seen. Along with that, there is central liquefactive degeneration. So this is actually the central liquefactive degeneration, which is the accumulation of either serous fluid, or here there is accumulation of either serous fluid, or there is accumulation of blood, or colloid is seen in the acini. So this completely we call it as either hyperplastic or adenomatous, or we can also call it as colloid nodules, because these follicles are dilated and they are filled with colloid like substance. So this is called as colloid nodules also. So there is cystic degenerative process is seen with calcification, can also be seen in certain areas. Okay. Now this is what is seen histologically. Then what are you going to see in ultrasonography? In ultrasonography, this is a nodule. The nodule can either look homogeneous, that is, it can be either isoechoic, number one, compared to the thyroid tissue, or it can be hyperechoic. Okay, so this hyperechogenicity which is seen here is mainly because of the uh, interfaces which are seen, because of numerous interfaces or artifacts which are seen between cells and colloid. Between cells and colloids, because of the numerous interfaces, you will see that the nodules are hyperechoic, or the nodule can be Here, if you hyperechoic with a halo, so you can see here the nodule is again hyperechoic, and this nodule is actually surrounded by a hypoechoic halo. Okay, you can see a hyperechoic nodule surrounded by a hypoechoic halo is also seen. Why is this hypoechoic halo? This hypoechoic halo is mainly caused by the blood vessels which are present around the nodule. So it is caused by perinodular blood vessels. The perinodular blood vessels will result in hypoechoic halo, which is seen around the hyperechoic nodule. Okay, next. So, this is also the picture of benign nodule. Okay, in the benign nodule, which you can see here, you will see that this is number one. Definitely, this is hypoechoic, right? So this is less in echogenicity when the surrounded tissue. So number one, it is hypoechoic and it looks like sponge, right? It is either a sponge like, or you can see that it is also a honeycombing pattern. So it is hypoechoic, honeycombing pattern is seen in these nodules also. Okay, this is a sponge-like or honeycombing pattern with small or larger cystic spaces. These are the larger cystic spaces. This is the smaller cystic spaces which are seen in the nodules. These are also benign in nature. So, has already said, there is a hyperechoic center with peripheral halo is seen. This is also a sign of benignity. That means presence of peripheral halo in the thyroid nodule like this is also a sign of benign nature according to this article. Then we have different types of vascularity is also seen. There can be perinodular vascularity, that is around the nodule. You will see the vascularity which is seen here, or you can also see intranodular vascularity, that is inside the nodule also you can see the vascularity. As the vascularity increases, the doubt or the suspicion that the nodule is malignant will also increase. So this is also from an article actually. So according to this article, mostly the increased vascularity is mainly seen in benign nature. In most of the adenomas, you will not see any vascularity. Majority of cases, vascularity is absent. See, they lack vascularity. Only a few tumors are vascular. That is, hypervascular tumors are most commonly they are malignant. So obviously they can be either adenoma or adenomatous nodules, or they can be any types of follicular variant or any other type of papillary carcinoma, or they can be follicular carcinoma. Then, if you see the colloid cysts, so as we have seen in the histological cases, the center, that is, if you see this histology, this is the thyroid follicle. Inside the follicle, there is degeneration. Liquefactive degeneration occurs. As a result, serum, blood, or colloid like fluid gets accumulated inside this follicle, right? So, if you see here, this is the colloid or serous, which is seen as anechoic areas. Here you can see the anechoic areas, right? This is anechoic. So this anechoic area is mainly because of the serous or colloid fluid, which is seen in the nodule. That is number one. Number two, sometimes you can also see that the fluid has echogenic foci, right? So this is that echogenic foci which is seen. This echogenic foci is called as comet tail artifacts. Okay, so these comet tail artifacts are mainly caused due to microcrystals or due to the aggregates of colloids. That is, a group of colloid crystals might become aggregated, or they might become combined together to form a crystal-like substance, resulting in microcrystal-like substance, resulting in this comet tail artifacts might be seen. Okay, and okay, sometimes you can see that inside you might see an echogenic material. See, this has internal echoes. Okay, this internal echoes, if the fluid inside has internal echoes, then you should always suspect that it is bled due to some hemorrhage. So hemorrhage should also be suspected if there are some internal echoes seen inside the nodule. Okay, sometimes we can also see thin intracystic septation can also be seen, like um, uh, intracystic septations like this. Here you can see some septations, right? So you might also see presence of thin intracystic septations can also be seen inside the cyst. Okay. Sometimes what happens is these degenerative process which is happening, that is liquefactive degeneration which are happening, these will result in formation of calcification. So these calcifications can be of two types. One, they can be thin peripheral shells like eggshells. They can be thin peripheral shells like eggshells, or they can be coarse reflective foci. That means, so if you see this picture here, this is the calcification. Okay, the sound waves are falling like this, and there is peripheral shadowing is present here. Here, see, nothing is visible. Nothing which is seen behind this calcification center is visible because this calcification is a highly reflective surface. So, as a result, all the sound waves which are reaching this classification with this calcification are reflected away and they are picked up by the transducer. So, as a result, anything beyond this calcification is not visible in this spectrum, in this view. Okay, so this is actually a type of force reflective surface or reflective foci. Okay, the second type is thin eggshell. So this is actually an eggshell. In eggshell, it is thin, and as a result, you can see the peripheral part also. Okay, so these are the two different types of calcification. One, coarse, highly reflective foci with acoustic shadow. This is actually an acoustic shadow. Okay, and second type is thin peripheral eggshells are seen. So these two are the types of calcifications which are seen in hyperplasia or goiter. Then, then in order to differentiate between benign and malignant, one more important thing is contrast enhanced ultrasonography. In contrast enhanced ultrasonography, if you see, benign lesions will not show any enhancement, whereas malignant lesions will show intense enhancement in the arterial phase. So you will see that there is enhancement seen in arterial phase in malignant lesions. So if you see an example, actually this is this one which is seen here. This is actually a mixed solid to cystic lesion, right? It is mixed to solid to cystic lesion is present. And this is normal ultrasonography. This is contrast enhanced ultrasonography. That means you have given contrast to this lesion. So what are you seeing here? Here it is looking as a complete anechoic system. That means the inside this solid material which is present, this has not been enhanced. This is a clear cut picture that it is a benign lesion. Whereas if you see here, this is the This is completely cystic and there is small area of solid here. This is very small area of solid. Okay. And if you do a contrast enhanced ultrasonography of this lesion, you will see that this lesion is visible here. So this is the lesion which is showing enhancement in arterial phase. So this is actually a malignant lesion. And one more important thing is about the vascularity. Okay, the vascularity of the thyroid of the vascularity of this colloid nodule. Okay, this colloid nodule can have um, vascularity something like this. So it has a peripheral flow. The colloid nodule will have peripheral flow and there is no central flow. Okay, so this will also tell us that it is a benign lesion. Thank you.